Imagine having this severe, just agonizingly painful skin condition.
Oh, the kind that literally keeps you awake at night.
Right, exactly. It completely disrupts your daily life, and it can even like fundamentally alter your anatomy over time. So you finally go to the doctor desperate for relief, and the newest, most innovative alternative treatment they hand you is a cream that literally burns your skin when you apply it.
I mean, it sounds incredibly counterintuitive. It's almost like a cruel joke being played on the patient, honestly.
It really does.
But that contradiction is actually at the very heart of one of the most intense debates in modern dermatology right now.
And that is exactly what we are getting into today. Welcome to this deep dive. If you live with an autoimmune or a chronic condition, you already know the drill here.
Yeah, that heavy dread of a lifelong prescription.
Yes. You know that unique dread of being handed a medication that you're going to have to manage for the rest of your life. You're perpetually walking this tightrope, trying to balance the immediate, desperate need for symptom relief against the long-term and sometimes really scary side effects of the meds themselves.
Which is a terrifying position to be in.
It is. So today's deep dive is really about understanding the safety of those safety nets. We are looking at a condition called lichen sclerosus, or LS.
And just for those who might be unfamiliar, LS is a chronic inflammatory skin condition. It primarily affects the anogenital area, though, it can appear elsewhere on the body.
Right.
And it causes severe itching, tearing, pain, and if it's left unchecked, permanent scarring and irreversible anatomical changes.
Which is just awful.
It is. It's an incredibly challenging condition to live with, and the maintenance is lifelong.
So to get to the bottom of how to actually manage this, we've been combing through a literal mountain of conflicting international medical guidelines today.
Oh, yeah, we've got everything from European health boards to the British dermatology societies.
Right, alongside clinical trial data, Mayo Clinic insights, patient advocacy resources, you name it. And the crazy thing is, they are completely divided on one specific issue.
They really are. The consensus just completely fractures when it comes to the long-term management strategy.
Which brings us to our actual mission for this deep dive.
Yeah.
We are trying to answer this one question. Can topical calcineurin inhibitors, which we'll just call TCIs for short, can they be safely used as a long-term maintenance therapy for lichen sclerosus?
And to understand why this question has patients and specialists so deeply divided, we really first have to look at what is actually happening at a microscopic level.
Like in the skin itself.
Exactly, in the skin of someone with LS. The prevailing research indicates that this is driven by a localized immune reaction. Essentially, the immune system in this specific region of the body receives a false alarm.
A false alarm, okay.
Yeah, and it goes into absolute overdrive, targeting the very bottom layer of the skin, which is known as the dermis.
So the body's defense mechanism is essentially attacking its own infrastructure.
That is the core of the problem, yeah. You have these immune cells flooding the area,
Yeah.
triggering massive inflammation, and this inflammation literally breaks down the healthy tissue.
Wow.
So the intense itching that patients experience, it isn't just a surface irritation, It's a profound neurological and inflammatory response to that actual tissue damage.
So it's not like a mosquito bite.
No, not at all. And as the skin tries and fails to heal properly in the middle of this ongoing battle, it scars over. And that's what leads to the skin fusing together and tearing so easily.
So the medical goal, obviously, is to stop that immune system attack. Like, if your immune system is a raging fire destroying a house, you need to put it out.
Precisely.
And my understanding is that right now, the undisputed first-line champion of doing that is a very specific, incredibly strong medication.
Right. We are talking about ultra-potent topical corticosteroids.
Yeah.
The vast majority of cases, it's a drug called clobetasol propionate. It is the absolute gold standard across nearly every medical guideline we reviewed.
I like to think of that kind of drug as a chemical fire blanket. Or, honestly, even a carpet bomb.
A carpet bomb is a good way to put it.
Yeah, because you have this raging inflammatory fire in the localized skin, and the clobetasol just drops right on top of it and heavily smothers the entire local immune response. Like, everything just gets shut down.
That analogy actually holds up really well when you look at the mechanics.
Yeah.
Because clobetasol permeates the skin cells and essentially turns off the genetic switches that create inflammatory proteins,
Right.
while simultaneously turning on the switches for anti-inflammatory proteins. It works brilliantly to put out the fire.
But there's a catch.
There's a massive catch.
Yeah.
We run into a significant psychological and physiological barrier with patients. It's something documented widely in the clinical sources as steroid phobia.
Which I mean, is completely understandable.
Oh, entirely.
Because if you're a patient, you've probably been warned since childhood that steroids thin the skin. I remember my mom telling me that about hydrocortisone.
Right, exactly. Everyone hears that.
And now a doctor is telling you to take the strongest steroid available and put it on the absolute most sensitive, delicate skin on the human body every single day for a month and then twice a week for the rest of your life.
The apprehension is incredibly valid. When you use a broad immunosuppressant like an ultra-potent steroid, there can be collateral damage if it's misused.
Like what kind of damage?
Well, we were talking about severe skin thinning, which clinically we call atrophy. The skin can become almost transparent and incredibly fragile, tearing even more easily than it did from the disease itself.
Oh, wow. So it almost mimics the disease damage.
It can, yeah.
Yeah.
Patients can develop dilated blood vessels. There's even a risk of glaucoma if the medication is accidentally transferred from the hands to the eyes over time.
Yikes. So people read these warning labels, they experience that fear, and they just, what, stop using it?
That happens constantly. Specialists stress that proper controlled use of clobetasol is safe, but that fear drives really poor compliance. Patients abandon their medication, the fire flares back up, the tissue starts scarring again, and the disease just progresses.
It's a vicious cycle.
It is. And this massive compliance issue is what drove the medical community to search for an alternative in the first place. We needed something that stops the inflammation without that specific collateral damage.
Which brings us to the challenger in our deep dive mission today, topical calcineurin inhibitors, or TCIs. The sources mention drugs with names like tacrolimus and pimacrolimus,
Yes,
and they are non-steroidal.
they are non-steroidal immunosuppressants. And what's interesting is they were originally developed and licensed for severe eczema. But dermatologists began utilizing them off-label for lichen sclerosus, specifically to avoid those steroid side effects.
Okay, so if the steroid is a carpet bomb that just flattens the whole immune response, how does a TCI work differently?
Let's break down the actual name. Calcineurin is an enzyme in your body. Its main job is to activate your T cells.
Okay.
You can think of T cells as the frontline generals of your immune system. In a patient with LS, these generals are constantly shouting orders to attack the local skin tissue.
Right, the false alarm.
Exactly. So what a TCI does is bind to a specific protein, which then blocks that calcineurin enzyme from working.
So if the enzyme is blocked, the T cell general never gets the megaphone.
Yes.
The orders to attack are just never given.
It's a much more targeted approach. Instead of a carpet bomb that affects all the surrounding tissue structures, it's more like a sniper taking out just the specific communication lines of the inflammatory cells.
That's fascinating.
What's fascinating here is, because it operates this way, it doesn't interfere with the collagen synthesis in the skin cells themselves.
Wait, if it doesn't interfere with collagen, does that mean no skin thinning?
Zero risk of skin thinning.
Really?
Zero risk of the tissue fragility associated with steroids,
Yeah.
and zero risk of causing those permanent stretch marks.
Okay, let's pause right here. If TCIs can turn down the specific immune response, stop the inflammation, and they have absolutely zero risk of thinning the skin, I mean, that sounds like the absolute holy grail for a lifelong maintenance cream.
It does sound perfect on paper.
Why isn't every single person with LS immediately prescribed a TCI? Why are they only considered a second-line off-label treatment?
It's a fantastic question, and to answer it, we really have to look at what happens when you put these two medications into the ring together in head-to-head clinical trials.
Let's look at the actual data.
So the clinical sources confirm that TCIs definitely work. One phase 2 trial utilizing tacrolimus showed a 77% response rate in patients.
Wow, 77%.
Yeah, and another study evaluating pimacrolimus demonstrated that 42 to 43% of patients achieve what they call complete remission after 6 months of application.
Complete remission in this context meaning, what exactly? Just no itching.
It means a total cessation of the active disease symptoms. So no itching, no pain, no active inflammation visible to the doctor at all. For a patient, I mean, that translates to sleeping through the night again, being able to exercise without pain, and halting any further scarring or architectural changes to their body.
Which is completely life-changing.
It is life-changing.
Almost half the patients getting their life back is an incredible statistic. So where does it fall short?
Exactly. I mean, it seems like it shouldn't fall short at all. But the caveat reveals itself when researchers conduct double-blind, randomized controlled trials comparing TCIs directly against clobetasol propionate.
The heavyweight champ.
Right. In these scenarios, where neither the doctors nor the patients know which cream is being applied, the steroids consistently outperform the TCIs.
Really?
Yeah. The clobetasol provided significantly faster relief of symptoms. And more importantly, at the end of a 12-week trial, when they looked at the tissue under a microscope, far fewer women in the steroid group had active underlying LS inflammation compared to those using the TCI.
Okay, so the carpet bomb is just undeniably stronger and faster at putting out the fire than the sniper is.
That's what the data shows.
But there's another major hurdle with TCIs that I found in the patient advocacy resources. And this brings us back to the hook we started with.
Ah, yes. The side effects.
Okay, let's unpack this. Because you're telling me that the treatment for a skin condition characterized by intense, agonizing, itching, and painful open microtears is a cream that literally burns you when you put it on.
Yes.
How do doctors convince anyone to stick with that?
It's one of the most frustrating paradoxes in dermatology, honestly. The most notorious short-term side effect of both tacrolimus and pimecrolimus is a severe local reaction.
Like how severe?
Patients experience intense stinging, burning, and sometimes an exacerbation of the itching right after application.
Why does it do that? If it's calming the immune system, why does it feel like lighting a match on the skin?
It basically comes down to a localized neurological reaction. The current understanding is that TCIs initially trigger the release of something called substance P from the nerve endings in the skin.
Substance P.
Yeah. Substance P is a neuropeptide that transmits pain signals to the brain. So before the drug can calm the immune system down, it basically empties out all the pain signaling chemicals in the immediate area.
But the key phrase there is that it empties them out, so it's temporary.
Highly temporary. The burning usually peaks in the first few days, and because those nerve endings literally deplete their stores of substance P, the burning fades completely within a week of continuous use.
But you have to push through the fire to get to the relief.
And that is a massive point of failure in treatment. Just think about the psychology here. If a patient isn't clearly warned about this mechanism by their doctor, they apply the cream to an area that is already incredibly sensitive and damaged.
And it burns terribly.
Right. They immediately assume they are having an allergic reaction or making the disease worse, and they throw the tube in the trash.
Yeah.
Comprehensive patient education is absolutely critical here. You have to counsel them to push through that initial week.
So, assuming a patient gets that education, they push through the burning, they deplete the substance P, and they are okay with the TCI being slightly less potent than a steroid because they really want to avoid skin thinning.
Right.
It still seems like a totally viable option. But here's where it gets really interesting, and frankly, this is the crux of our entire deep dive today. We have to talk about the long-term safety paradox.
This is the big one.
Yeah. If you have to use a maintenance cream on your most sensitive skin for the next 40 years, is a TCI actually safe?
To understand the safety profile of the treatment, we first have to understand the inherent danger of the disease itself. Untreated or poorly controlled lichen sclerosus carries a small but very real risk of developing a specific type of skin cancer.
Which kind?
It's called squamous cell carcinoma, or SCC.
How small is the risk? And, well, why does a skin condition cause cancer in the first place?
The data suggests the risk is under 5% over a patient's lifetime. As for the why, it goes back to that chronic inflammation we discussed earlier.
The fire.
Exactly. When your immune system is constantly attacking the tissue, the cells in that tissue are constantly having to divide and replicate to repair the damage. And every time a cell divides, there's a tiny chance of a typo occurring in its DNA.
The mutation.
Right. When you force the skin cells to rapidly divide in a highly inflammatory environment for years on end, the mathematical probability of a malignant mutation, a cancer, skyrockets. The constant cycle of destruction and repair is what drives the SCC risk.
And here is the crucial, proven fact about those ultra-potent steroids. Regular long-term maintenance with a steroid like clobetasol has been clinically shown to reduce this risk of cancer almost to zero.
It's amazing.
By thoroughly smothering the inflammation and stopping that rapid cycle of tissue damage and repair, the steroid actively protects the patient from developing cancer.
The clinical data on that is incredibly robust, and it spans decades. Steroids prevent the structural damage, and they prevent the cancer. So the obvious question becomes, where do the TCIs fall into this cancer prevention model?
And this is where we hit a massive, glaring divide in the international medical guidelines. I was looking at the European guidelines in the British Society for the Study of Vulval Disease, the BSSVD,
Right.
and they issue very stern cautionary warnings about TCIs. Because these drugs suppress the local immune system, these regulatory bodies warn that they might theoretically increase a patient's susceptibility to malignancy, or that they might accelerate the growth of existing abnormal cells like those related to HPV, the human papillomavirus.
The logic there stems from the basic function of the immune system. Your immune cells aren't just fighting off infections, they're also constantly patrolling your tissue, identifying and destroying mutated cells before they can turn into tumors.
It makes me think of turning off the security cameras in a neighborhood that already has a high crime rate. You know, the lichen sclerosus neighborhood is highly prone to squamous cell carcinoma, and now you're sending in a sniper to take out the local immune guards. Are we just giving cancer a free pass to develop?
That theoretical fear is exactly why the European guidelines treat TCIs with such intense caution. Some of these guidelines strictly advise against using a TCI continuously for longer than 2 years without heavy specialist supervision.
2 years, wow.
Yeah, they view the localized immune suppression as a significant long-term risk.
But then you turn the page to the British Association of Dermatologists, the BAD, and they offer a totally opposing, very reassuring view.
They do, and their stance is backed up by several recent scientific reviews, including a major comprehensive analysis from 2021. The BAD patient leaflets and these newer data sets state definitively that there is no clinical evidence that topical TCIs increase the risk of squamous cell carcinoma in LS patients.
No evidence at all.
None. The argument here hinges on systemic absorption versus local application.
Meaning how much of the drug actually gets into the bloodstream.
Precisely. When a patient takes oral immunosuppressants, like pills that affect the whole body, the risk of various cancers undeniably goes up because the entire systemic immune patrol is suppressed.
That makes sense.
But when you apply a topical TCI, like tacrolimus, to the skin, less than 0.1% of that dose is absorbed into the bloodstream. It's an almost negligible amount. The systemic immune suppression simply doesn't happen.
So we have two distinct camps here. One side says, it turns off the local immune guards. Be careful, it might cause cancer. And the other side says, it barely absorbs into the body. We have zero proof it causes cancer after years of use, so don't worry about it.
Pretty much.
How on earth is a patient or even a general practitioner supposed to navigate that contradiction?
If we connect this to the bigger picture, it ultimately comes down to the burden of proof, the length of time we've been observing these specific drugs in this specific population, and honestly, the comfort level of the medical community.
The history of it.
Sure. Yes. We have 40 years of clinical data proving that steroids prevent LS scarring and prevent squamous cell carcinoma. It is a massive, highly proven safety net. We just don't have that same 30-year or 40-year safety net of data for TCIs yet.
Because they haven't been used for LS long enough to track lifetime cancer rates.
Correct. We lack the definitive multi-decade proof that TCIs halt the progression to SCC the way clobetasol does. And when a dermatologist is dealing with a disease that has a known, documented pre-malignant potential, they're going to be incredibly hesitant to abandon the proven lifesaver for a newer alternative.
Especially for a prescription that the patient will use for the rest of their life.
Exactly.
So if we pull all of these threads together to finally answer the core mission of our deep dive, can TCIs be safely used as a long-term maintenance therapy for lichen sclerosus? Where does the verdict land after analyzing all these conflicting sources?
The verdict is that TCIs are an incredibly valuable, safe, and effective tool in the dermatological arsenal, but with strict caveats. They are fantastic for managing short-term flares. They are essential for patients who have true allergic reactions to steroids, or for those whose skin is already thin to a dangerous degree.
Right, the exceptions.
But for the ultimate goal long-term, lifelong maintenance to keep the disease entirely in remission and protect the patient's future health, ultra-potent steroids remain the undisputed king.
The heavyweight champ holds the title.
They do. Their ability to halt structural damage and actively prevent cancer is proven by mountains of data. The long-term cancer prevention profile of TCIs still has a question mark hanging over it, which firmly keeps them categorized as a second-line treatment.
So what does this all mean for you, the listener, if you or someone you love is navigating this overwhelming diagnosis? It means you shouldn't let steroid phobia dictate your treatment plan.
Absolutely not.
The guidelines across the board are incredibly clear. If you use these ultra-potent steroids correctly, the risk of skin thinning is incredibly rare. The reality is that active, uncontrolled lichen sclerosus will do far more damage to your skin and your anatomy than the steroid ever will.
That is the most important takeaway.
And just to put the actual medication amount into perspective, a single standard 30-gram tube of clobetasol should safely last a patient anywhere from 3 to 6 months when they are on a maintenance dose. We are talking about an amount the size of a pea. A tiny controlled amount goes a very long way to protecting your long-term health.
I think framing it that way is vital for patient peace of mind. But before we finish up today, I want to leave you with a final thought that looks beyond the current paradigm of both steroids and TCIs.
Ooh.
Yeah, as we dug through the recent clinical trials in our sources, there is some fascinating emerging research into treatments like PRP, platelet-rich plasma, and stem cell fat grafting for lichen sclerosus.
Meaning using the patient's own blood and fat cells to treat the skin.
Yes, think about the mechanisms we've discussed today. Steroids work by aggressively smothering the immune system with a carpet bomb. TCIs work by selectively turning the immune communication lines off like a sniper. Both rely on suppression. But what if the future of long-term maintenance isn't about suppressing the body's natural functions at all? What if, by utilizing the growth factors concentrated in our own blood platelets and the regenerative stem cells found in our own fat tissue, we could simply reprogram the damaged skin to rebuild and heal itself?
Wow. That changes the entire conversation. Suddenly, you aren't just walking a tightrope, desperately trying to balance symptom relief against the long-term side effects of an immune-suppressing safety net. You might just be walking on solid ground.
Exactly.
Something to think about as medical science keeps pushing forward. Thanks for joining us on this deep dive, and we'll see you next time.